am Ms. Sainudheen, working as a clinical resource nurse in Al Qasmi Hospital, Sharjah, United Arab Emirates. I would like to thank the organizers for inviting me to the first GIS CVP conference, and it's my privilege to be presenting here. So today I'm going to take you through the quality improvement in the Cath lab, and some of the data which I'll be showing you is from my institution. So, do you think quality improvement or quality in the Cath lab is important?
Yes, sir.
Yes, of course. Even if we do a lot of procedures, we use the latest technology. If you don't have the quality in what we do, it's of waste, right? So enhancing operational efficiency in catheterization laboratories is essential for delivering high quality and cost-effective patient care. The implementation of streamlined workflow processes within clinical and operational activities not only optimizes efficiency, but also contributes to better clinical outcomes, improved patient safety, and higher levels of staff engagement and satisfaction. So today my objective will be to discuss the clinical focus areas, the operational focus areas, and I'll display some outcome measures. So coming to the clinical activities, the first is the patient safety protocols, which we all implement in our daily life, daily work in the Cath lab, which includes the infection control practices, the radiation safety, the monitoring. These are all implemented, I think, in all the Cath labs. And then we should have some standardized clinical pathways or protocols. So in our institution, we have two pathways, which is management of acute myocardial infarction and management of advanced atrioventricular block, which is accredited by the Clinical Care Program Certification as part of the JCIA. Then team communication and collaboration. So nothing will work, nothing will improve without a proper team collaboration, a multidisciplinary team approach, and also standardized communication tools. So standardized communication tools such as SBAR for handover, whether it's between the nurses, the physicians, or any multidisciplinary team, will improve the standards. And also using a pre-procedure checklist and the WHO surgical safety checklist, which you all are familiar with, which includes the sign in, time out, and sign out, yes. Now coming to the next activity is reducing our procedure times. So this can be measured through key performance indicators, door-to-wire time for referral patients, that is the door when they reach our emergency department should be less than 60 minutes. Diagnosis to wire times for patients presenting to our emergency department directly. Fluoroscopy time during primary PCI procedure less than 15 minutes. Device procedure times less than 133 minutes. Length of stays less than 2 days for device implantations. So this is some of the data. This is our data for 2024 for the primary PCI from diagnosis to wire. And our target is less than 60 minutes. This is another data for the fluoroscopy time. Next, clinical activity is reducing or improving the post-procedure care and outcomes. The KPIs which we measure in hospital mortality rate in acute MI patients, post-primary PCI, contrast-induced nephropathy, percentage of acute MI patients whose primary PCI is done through radial access, percentage of patients attending rehabilitation clinic post-primary PCI, percentage of new pericardial effusion after device insertions, percentage of pneumothorax detection post-device insertion, and percentage of pocket hematoma. Coming to some data. So in hospital mortality rate in acute MI patients, our target and benchmark is less than 44%, and we have achieved it during the year 2024. In acute MI patients where the primary PCI have done through the radial access, also we have achieved the target. Contrast-induced nephropathy, during the last year, like 2 months, we were above the target, whereas our benchmark is 3.3%, benchmarked with the Institute of Nephrology. So coming, now we have seen the timings, the KPIs. So one of the most important activities is the training of the staff. whether it's a nurse, it's a cardiovascular technician, radiographer, whoever is part of the cath lab team. So, being a nurse educator, I would focus more on the nursing education. So when a new nurse arrives to the cath lab, we have some mandatory competencies for them to be completed. There are some core competencies, life support courses, which will enable them to be a primary nurse in the cath lab. Okay? And then we have some unit-specific competencies. So the first 3 months, the new nurse will be assigned with a preceptor who's a new senior staff who will be guiding her, training her throughout the inception into the cath lab, along with the support of the clinical resource nurse who's assigned to the cath lab. And during her first week of joining the cath lab, we do a learning need assessment, and based on the learning need assessment, we prepare an individualized education plan for that particular staff. So that is the process for the new nurse. So for the old nurses or senior nurses who are experienced working in the cath lab for a long time, we still do a learning need assessment on a yearly basis, and based on the analysis of all the staff learning needs, we do an educational plan for the coming year. Usually we do it in November, the analysis, and then plan for the coming year. In addition to this, in our cath lab, we have a daily huddle in the morning, and we always have a 5 to 10 minutes of education sessions where we discuss about the updated policies, any new procedures, any new medications, anything which is introduced into the cath lab. And this is done by the staff in the cath lab itself. And the most important, patient experience. We need to measure the patient experience or patient satisfaction during their journey in the cath lab. We do a patient experience survey. We call it as customer pulse survey. And also, we take care of the patient's complaints. We have a specific time period of 48 hours to deal with the patient complaints, and we try to resolve the complaints within this 48 hours. So those were the clinical activities to be focused. Now coming to the operational activities. So for the operational improvement, we have streamlined workflow processes, and in the workflow process, each step in the workflow process, we have defined the clear roles and responsibilities of each staff member. By defining these workflow processes for elective and emergency procedures and defining the roles and responsibilities, making each of them aware of what is their roles and responsibilities, we were able to achieve a quality improvement in our cath lab. So the operational activities, we were focusing on prime time utilization. Our prime time is from 7:30 in the morning until 3:30 in the afternoon. And on-start time to be at 7:45 or 7:45 a.m., cancellation rate of less than 5%, no-show rate of less than 5%, turnaround time of less than 20%. So after implementing, we have achieved the prime utilization, which was 38% in 2023. We have improved it to 60% in 2024. And on-start time improved from 12% to 61% by end of the year. So while implementing this quality improvement in the cath lab, we have faced some challenges. There was resistance from the staff members. We had some lack of resources, like our staffing was very bad. And then funding, staffing always comes with the funding as well. And the data collection and analysis challenges we had, and balancing quality improvement with daily operations. So we have overcome the challenges by using regular training and education, fostering a culture of quality among the staff members, using advanced technology and leadership commitment. So to conclude, continuous monitoring, staff training, and data-driven decision-making will be key to sustaining these improvements in the cath lab. Through ongoing collaboration and adaptability, we can ensure that these streamlined processes to enhance efficiency, support high-quality patient care, and can drive organizational excellence. Thank you for listening. If you have any questions,